Hi, everyone. Good afternoon. Just going to wait for folks to be able to join, log in, and so we'll give folks a moment. As you are logging in, welcome. I'm Bethany Hamilton, co-director of the National Center for Medical Legal Partnership. I have my colleagues on, Danielle and April. So they'll be on monitoring and ensuring that you have access to all of the fixings here on Zoom to be able to listen in, chat with us. But as you log in, we'll go ahead and have a poll running just to get a sense of who is actually joining us today compared to what we know of the registration number. So April will start a poll and just let us know. We'll keep it running for a while as people continue to log in. Also, as you're logging in and waiting for us to get started, we do want to make sure we sincerely thank you for joining us today. We know you are super busy. Just before launching the webinar, we talked about reg numbers and how much people are doing to really step away from their day-to-day work to join us on a training call. So we really appreciate you joining us. It is Mental Health Awareness Month, and we are presenting this webinar with that in mind. And so we wanted to plug a resource from one of our fellow National Training and Technical Assistance partners, the Migrant Clinicians Network. They've offered a really awesome program called the Witness to Witness program, and it provides peer support groups for really the workforce that works with vulnerable populations and may experience some of that sort of like transfer of stress or trauma, or that compassion fatigue, or the burnout. So feel free. I encourage you all to check out what the Migrant Clinicians Network is doing with the American Family Therapy Academy through their Witness to Witness program. We'll make sure everyone gets a copy of the slides so that you are able to take advantage of everything that we've hyperlinked. All right, so it looks like we've received a majority of answers to the poll. That way it can get rolling here. We have a lot of legal services partners on here, community health centers, FQHC lookalikes, PCA folks, hospitals, law school folks. So thank you so much for joining us. Let's go ahead and close the poll out. And for those who might be just logging on and missed the poll, please feel free to go ahead and type into the chat box, especially if you're from a community health center or an FQHC lookalike, because this is a HRSA funded webinar. Let us know where you're from. All right, so welcome. Again, I'm Bethany Hamilton with the National Center for Medical Legal Partnership, and you are joining us on May 18th, 2021 for our national audience webinar addressing financial and legal problems to improve the mental health of adults and children during the pandemic. Today, you'll be hearing from our guest panelists. We're very happy to be joined by Dr. Eric L. Bogan. He's with the Durham VA Healthcare System and Duke University, and an MLP practitioner, Marisol Garcia of Health Law Advocates in Massachusetts. Few housekeeping items. I'll go through this very quickly. Make sure, and hopefully you can hear me. Turn up your volume if you're having any trouble hearing us today. We've got at least one person in the background taking AP exam, so good luck to her. Good luck to her. But turn up your volume if you can't hear us, because it might be a little hard for us to speak up any more than we are. Everyone is joined on mute. Please go ahead and use the chat box to send us your questions or comments. And also, of course, let us know who you are joining us today. If you do need help, go ahead and email our colleague, April Daniels at gwu.edu. And please, 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 because HRSA likes it when we collect data on satisfaction, please complete the survey at the end. I'll provide a reminder. Again, I mentioned that this is a HRSA funded webinar. So we primarily are joined by, and we'll tailor our remarks today for the community health centers or the FQHC lookalikes or the PCAs, but many of the legal services partners, the law school folks, even the hospitals are also collaborating and working with health centers. And so you will find, I think for this particular webinar, that the content and the materials are really, they transfer or easily are transferable across the board and applicable in various settings. All right, so we're going to run another poll to get a sense of what you're working on. The quote on the screen really is from NIMH, really describing mental health, and they describe mental health as much more than the absence of mental illness, explaining that it's essential to your overall health and quality of life. So for the folks who are taking a moment today to really, I think, train up and hopefully receive new content, improve their MLPs in themselves, tell us, first of all, do you have an existing MLP? Great, lots of MLPs. Let's leave it running for just a few more seconds before we close out. Make sure we've got, we're about 80% respondents for those who are logged on. And we'll close it in 3, 2, 1. All right, April can close that out and we'll share the results. So we've got about 73% of the people logged in with MLPs. And oops, looks like hopefully I shared the results there. About 73% of the folks on with us today have a medical legal partnership. For those of you who are not yet operating an MLP, no worries. Again, this content will be applicable because we're talking about research as well as interventions related to, excuse me, how financial strains, just as high debt, low income, unemployment, all of those things we saw exacerbated by the pandemic, not caused by, but exacerbated by the pandemic, how those are associated with suicide attempts and should be considered factors when assessing mental health interventions, such as what we'll purport today, MLP, and then how legal services, when they're delivered alongside social, medical, and behavioral health services, can really improve the overall health, not just adults, but also children. So the two subject matter experts that we'll have speaking today about these two subjects, again, are Eric L. Bogan and Marisol Garcia. I'm going to provide a quick overview for those of you who are not with MLPs in place yet, especially about the approach. But today you won't see my pizza pie chart for MLP. You guys, I encourage you to go to the Health Center MLP Toolkit to see that. You've probably seen it a million times. And you can see our past webinars on it. What I really want to focus on is how when MLPs embed lawyers onto healthcare teams, the different ways that those lawyers or their teams in the legal services side of the equation are helping people. So if you are in a healthcare setting without a legal partner in place yet, you might be a clinician in an exam room and you're beginning to pick up on social needs since there's someone who's very concerned perhaps about an eviction right now. They may not say that they're facing eviction, but perhaps they're saying, yes, I'm really worried. My blood pressure is really high. I'm really stressed out. I can't pay rent. The news is saying everything about the moratorium being over. I have nowhere to go and I can't go back to work yet, right? Those are the sorts of things you might be picking up on in the exam room, or if you are admin, perhaps you're picking it up as someone's doing an appointment for screenings. So these are just some examples that the National Center put together in what we call the iHelp chart. And this is, again, a chart that you all are probably very, very familiar with, even if you don't have an MLP and you've just perused our website. So what's the impact that MLPs have had on mental health? The reason why we're here today. I should note that MLPs have been active in this space for a while with the opioid epidemic. Health centers and their legal partners work together to not just integrate behavioral health services, but really tailor and target those services in a way to be able to measure for positive impacts on mental health. And so the studies are showing that people have reported less stress and experienced improvements in mental health. In 2012, one of the earlier studies by Medical Legal Partnerships, it was a smaller study, but it was done on patients in Arizona where the MLP intervention was shown to reduce perceived stress and then result in improvements in overall well-being. Traveling through time with me here, in 2017, we saw an amazing study done on the veterans community in Connecticut and New York, where veterans were shown to have, and this is actually one of Dr. L. Bogan's colleagues who helped to conduct this study, veterans were shown when they had full legal representation to have significant reductions in those mental health symptoms, such as anxiety or PTSD symptoms. And then veterans were shown who had access to those medical legal partnership services, as opposed to those who didn't have as many services, they were shown to have greater improvements in their social stability and then also improvements in their mental health. Fast forward again, in 2018, we put out another issue brief where we highlighted the role that MLPs play in addressing the opioid epidemic and substance use disorder. And in NCMLP's issue brief, we also featured SAMHSA's dimensions of recovery. And we talked about how medical legal partnership or legal services in particular, when they're delivered through that MLP approach, can really function as a recovery mechanism or a recovery service or recovery tool. You can see where home and housing and shelter, right, is a dimension of recovery that clearly when lawyers are embedded through an MLP to address those sorts of needs when they arise, that they can certainly help to address those very serious threats to one's mental health and their ability to stick with or even enter a or make it through a recovery plan successfully. 2019, I'm going to highlight from my old friends at NAC from their 2021 Community Health Center chart book. The research team at NAC recently put out a chart book really showing that not only over the last 10 years have mental health services really grown exponentially through health centers, which we find, and I like to say, are the twins to the civil legal services community because of mission and the population served. But so have the ability of the health centers through their ability to ramp up and hire more behavioral health staff over the last 10 years. So we've seen increases in the services, increases in the staff at health centers. And then also in 2019, thank goodness this was done in 2019, was the ability to shift to tele-behavioral services. And so you can clearly see that according to the data, behavioral health services is where you saw the most telehealth uptick, and good thing that was in place before, where we are now, which is the chaos caused by COVID-19, right? We see all of these stressors caused by just a few of the headlines that I highlighted here on the screen, the access to vaccines, right? We saw the chaos and the amount of anxiety that caused for people in different settings, the entire stress placed on the essential workers, right, who weren't just in healthcare settings, but in supermarkets or picking up our garbage, right? Like these are, everyone's suddenly an essential worker and they're out there and they're stressed out, right, in truly hazardous conditions. KFF recently published an updated report and data on the mental health impacts of the pandemic. And we know that just a couple of weeks ago, it continues to play out with the eviction moratoria, threatening the shelter, housing, and stability of individuals. And that definitely would stress someone out, cause anxiety, and it just is like a cycle of triggering effects. Let's clear all of that out of the way. And let's talk about where we are now and what are the solutions. And so I'm going to definitely be quiet so you can hear from the subject matter experts on what the research is like right now and what it has shown just a year ago, and then what the MLP intervention looks like in this space. I'm going to stop sharing my screen so you can hear from and see Dr. El Bogan's slides first. All right, Eric, you should be able to share your slides next.
Hi, everyone. I'm the one who has a daughter in the other room with the AP exam, so I hope you can hear me. Do I see some thumbs up that you can hear me? All right, great. I can't talk any louder than this, otherwise we might get a disgruntled family member coming through the door. So in the next 15 minutes, I'm going to try to summarize for you what does the research say about financial strain and suicide risk. And the reason why this is, it would seem that this would be intuitive, but turns out most of the research has focused on mental health or medical variables like major depression or severe mental illness, with the idea that this will help clinicians, mental health clinicians, target suicide prevention efforts. So there's actually been not very conclusive research showing that financial strain is related to suicide. There have been a lot of studies that have looked at during times of economic prosperity, there's generally a decline in suicides, and the converse during times of, so during the Great Recession of in 2008, there are increased suicides. Uh, if you look at the literature, there actually, in the meta-analysis is a way, it's a study of studies, and it did show that if you look at it, people with unsecured debt are almost 6 times more likely to attempt suicide and 8 times more likely to complete suicide compared to those without debt. A study about a year ago showed that if you're looking over time as someone, and this would be of importance to a lot of what you're doing in the MLPs, right before someone is about to be evicted, that's actually a peak risk of when suicide occurs. And we published a paper showing that if you, and these were with veterans, if you ask a veteran, do you have money to cover basic needs? And then we asked them a year later, and this, they actually have triple the risk of saying that they're feeling suicidal if they don't have enough money for basic needs. So this seems to imply that financial well-being and suicide risk are connected. But one of the problems is a lot of the studies are cross-sectional. So it doesn't show that having financial strain at one period predicts in the future that you're going to have a suicide attempt in the next year or two. So it's all at the same time. So the problem is you're speculating. Well, maybe it's financial strain, but maybe it's that they're feeling depressed, or they have substance abuse problems, or they actually have past attempts in suicidal ideation. So the studies, and they've been non-representative samples, so it's been really unknown whether or not, or what link financial strain has on suicide. So what I'm going to present to you is data that we published a year ago. I'm also going to present data that we published, it was published a week ago on COVID, on the link between financial strain and suicide, where we attempt to control tease apart the financial strain and the mental health problems. And this was using data from what's called the NESARC. It's a nationally representative data set of almost 35,000 US adults. And there are 2 waves, and they're conducted 3 years apart. And so I'll give I saw that there's a lot of legal professionals on the call. Don't worry about a lot of the statistics if you don't have that in your background, because what I'm going to do is I'm just going to explain in plain terms. What this means is that if at the beginning of the study, someone said they had financial debt, then in the next 3 years, 2.8% of them reported attempting suicide, compared to if they did not have financial debt, less than 1%, so 0.62%. And you could see a similar pattern. Being unemployed was associated with higher rates of suicide attempts, income, and past homelessness. And just a quick, if it's statistically significant, the p-value has to be below 0.05. You could see those are way below 0.05. So the intuition that you all might have that these are related to suicide bore itself out in the data. And now this is a multivariable analysis. And what it means is the odds ratio on the bottom, let's say 6.06, means that people who had a history of suicidal ideation or attempts, suicidality, were 6 times more likely in the next 3 years to have suicide attempts. And that actually makes a lot of sense. What we found is that it was the cumulative financial strain from the homelessness, from the lower income, from the debt, from the unemployment, that cumulatively significantly predicted suicide when controlling for all those other variables you see there. And that means that financial strain is having an independent contribution, because you're statistically, this is a multivariable analysis. So that means you're statistically controlling for those demographics for major depression. And this had not been done before. And so what we really began to see is that it was this accumulation of these financial strain factors. And what you see is the vast majority of the sample had none of those. And their risk of suicide attempts was 0.004 in the next few years. Now look at what happens as, and this could be the people you're working with, as they begin to have more of those financial strain risk factors, if they have all four, that's 20 times higher risk than if they have none. And that is controlling for depression and history of suicide. This is just financial strain. And if it's beginning to, if that list looks familiar to you, that those are a number of the interventions of MLP. And so this is really beginning to tie together that there is data out there that ties the kinds of interventions that, that I help that are part of the MLP interventions that Bethany was talking about to this data. And just
sorry to interrupt you.
Yeah, please, please go ahead. Go ahead.
We can't see your slides advancing, and I hate to interrupt you, but I don't know if you want to go down on the slide deck, because all we see is, for our screens, it's stuck on the title slide. So I don't know if you're able to scroll down at least to that data slide that you were highlighting so folks can see it on the screen. In the meantime, I'll upload a copy of the PDF of the full slide deck so folks can see what Eric was talking about. But are you able to?
Sorry. So you're still on the first, I'm seeing them all.
Okay.
I think the issue is that when you might have to reshare your screen, Eric, and share your screen and not just the slide deck, so that when you advance, it's still advancing.
I can also screen share, Eric, to fix that for the audience. If you want me to do that quickly, I can do that. No problem.
Oh, I am so sorry. You have no idea what I was just talking about for the last 5 minutes.
No, we were following. We just couldn't see the slides. It was very clear.
You would need to see all of this. Oh, wow. So this is the first time I've ever given a PowerPoint where no one saw the PowerPoint in my life. All right. So you don't see anything at all?
We see your presenter's slide, so I can share for you. But we've also, just for folks in the audience, bear with us. We're, I don't know, 16, 17 months into the pandemic, so forgive us. The PDF of the slides have been uploaded to the chat, and so Eric, what I'll do is I'll go ahead and screen share so that folks can see what you're talking about. If you want to just say next slide, and then the animations built in.
Yes, I'm so sorry.
No worries, no worries. All right. And share. It happens.
Yes. Oh yeah, I wish I'd known earlier. If you want to go a few slides back. Oh yeah. So oh yeah, no, that was good. That was good. If you could go back to that slide, that's perfect.
Let me know.
Yeah, keep on going. Yeah, so what I was trying to explain of all this is that 2.8% of the people who had financial debt in the first year who attempted suicide in the next few years. And if you go through these, you see the patterns the same. And those p-values, this is like a memory exercise to see if you remember. If it's less than 0.05, and you could just keep on pressing the button. Thank you. Sorry, so that's all significant in the way that intuitively you'd think. The next slide shows those odds ratios I was telling you about. This is a statistics quiz. So the 6.06 on the bottom means that those people in the sample were 6 times more likely to attempt suicide. And you could see financial strain had an independent contribution when controlling for all those. And then the next slide, thanks, Bethany. This shows visually that those are financial strain risk factors that MLPs all address in terms of income, homelessness, employment, education. And that really translates, you could see at the beginning of the study, if they had none of those, they had a 0.004 chance of attempting suicide in the next 3 years. Whereas if they had all 4 of them, they had 20 times higher risk. And this is independent of mental health problems. This is the very things that your MLPs are intervening on. So, okay, if you could go to the next. And for the sake of time, I'll skip over these, but suffice it to say, we looked at change, and not surprisingly, having continuously being unemployed and continuously homeless. And then next slide, being in debt for both waves, and being below the median was associated with the most suicide attempts. So then here's some, and what we did then is, and I just will quickly go through this. This was published a month and a half ago. Someone looked at the same data set, and there were 2,500 variables that they looked at to see what were the top factors in suicide. And if you go to the next slide, what you could see, these are the, like, of those, it was almost 2,900. Number 7 was that item on financial crisis. And if you go to the next, 13 is job, 15 is income, 19 is income. So of the top 20 out of 2,500 variables, machine learning picked out 4, this is for suicide attempts, that are the kinds of things that MLPs intervene on. Okay, next slide. Lastly, we conducted a year ago a survey, a national survey of low to middle income adults in the United States, 22 or older. And we had a sample across the United States of 6,000 adults. And we wanted to look at whether or not financial stressors, social isolation, and mental health symptoms were related to thoughts of suicide. Next slide. And they were. COVID-related stress symptoms, so whether you were having a list of types of stress symptoms like losing sleep or irritability due to COVID, loneliness, and financial strain were each independently associated during COVID with thoughts of self-harm. And obviously all 3 of those are in part caused by COVID. We also found younger age, being a veteran, past homelessness, severe mental illness, not surprisingly, current depressive symptoms, alcohol misuse, and having been tested positive for COVID-19 was associated with suicide, through suicidal ideation. But relevant particularly is running out of money for basic needs, delaying rent and having some housing instability, filing for unemployment, and the food insecurity were related to thoughts of self-harm and suicide. Last slide. And those added up. So what you could see here is that if you were experiencing a high level of loneliness, you had financial strain, and you had COVID-related distress, you had a pretty high rate in our sample of reporting having thoughts. Now, this is not suicide attempts, but having had thoughts of self-harm or suicide compared to none. And those added up. Again, though, you could see from this, the B, which is the financial strain, that is having an independent and additive contribution to suicide risk above the COVID-related distress or dysfunction. Okay, and thanks, Beth. And I just, this is my last slide, and I think, Bethany and I have talked a lot about this. I think this is really important data to show that what medical legal partnerships are doing is, and that's the iHelp, at least the first 3 of the iHelp interventions. If to the extent that you're doing those are translating, according to our data, to potential improvement of mental health and possible reduction in suicide risk. I think that those graphs, I'm glad you got to see them, because I think what the take-home message would be to think about how they accumulate, and how the people who are in who you're serving in medical legal partnerships with these interventions, how you're able to help them go down and move to the other side of the graph where the suicide risk is lower. So thank you. Apologize. Don't know what happened with the technical stuff, but I was seeing it all here, so I don't know.
Okay. All good, Eric. It's happened to me on the last webinar I did. It's all good. It worked out fine.
Yep.
And that's a part of I think, Mental Health Awareness Month. We're woosawing through all of it. This is definitely, that's not the worst that could happen. So thank you. Let's run another poll before we switch to Marisol. And then I encourage everyone to please take, the time to use the chat box, throw your questions in there, since we have both of these subject matter experts on right now, because we're running on time, we're doing well. And once Marisol is done presenting, we'll be able to get to ample time for Q&A. So the question that's running right now in the poll is, are you working right now on behavioral health and mental health issues? That's whether or not you have a medical legal partnership. And if you are you working only with adults? Are you working only with children? Are you working with both adults and children? Or are you not working on behavioral health and mental health issues through your work, whether you're a healthcare provider, legal services, or otherwise? So we're still getting some answers in. Let's see if we can get to about 80% respondents. Go ahead and answer, or almost there. Take a moment, just answer the poll up on the screen. I know people multitask. I multitask on webinars all the time. So I get it. It actually helps me to pay more attention sometimes, I think. All right, cool. So we're going to close out in 1 second. Let's close out the poll and let's share the results. So it looks like about a little over a third of the folks on here are actually not working on behavioral health and mental health issues. We'd be curious to find out, for those folks who are not working on those issues, what setting are you in? Are you legal provider, healthcare provider? And let us know, what caused you to join today's webinar? What are you hoping to take away from it? What I'm hoping that Marisol can present next is for all of the folks who answered the polling question, and hopefully folks can see the results here. I'm not sure if I have to share it or not, but hopefully everybody can see the results here, that many of you are in fact working with adults and children. And so what Marisol Garcia is going to present is how in the state of Massachusetts, HLA is working, and I'm not going to steal her thunder here, but in a different kind of setting, to be able to bring those legal services to families and children. So with that, we're going to stop sharing the polling results, close out the poll completely, and then Marisol, let's make sure your screen and slides can share.
So hopefully you guys can see.
Yep.
Okay, great.
Let's make sure you're scrolling. Let's see if it scrolls.
You're not on my map?
Yeah, yep,
okay.
Good to go. Thank you.
All right, great, thank you. I'll pick up where Eric left off. I think what scientists are more careful about saying, but I'll just come out and saying is your work saves lives, is what Eric is saying. And I love that the data is there. And thank you so much for all the hard work that you do, because it is critical now more than ever, which is, I think, what Eric was showing us. So thank you, Eric. I'm really proud to be working with you all here today. So I'm at Health Law Advocates in Massachusetts, and I am the senior director there, and I lead the work of the mental health advocacy program for kids. I'm really proud to do that work. Our program improves the health and increases the educational success of kids with unmet mental health needs. We have experienced staff attorneys who provide free legal representation to income eligible families who advocate for access to mental health services and divert kids from the juvenile justice and child welfare systems. And what Bethany was alluding to earlier is that I call our partnership a clinical legal partnership. No one else does. It hasn't caught on, but I'm hoping someday it'll catch on, because we are not exactly with physicians. We are with in a community organization that was created by our Department of Children and Families. So our Department of Children and Families, which is in your state might be called a child welfare system or other protective services, they created these family resource centers. They were directed by the Massachusetts legislature to direct them, to create them when there were efforts here really to divert kids from the juvenile justice and child welfare systems. So for those of you who don't know, this is a map of Massachusetts. It's oddly shaped. You can see the Cape. We're all excited to get there. So the map of Massachusetts is in front of you, and my daughter helped me create this map with these stars on it. So the family resource centers are all the stars, right? So there are these community centers. They started out with one for each county, and then most counties have 2 and some counties have 3, depending on population and need. And so we have these family resource centers throughout the state, and my attorneys are based out of these family resource centers. So the darker stars are where their alphas are actually located, but we serve all of the FRCs. And just to tell you a little bit out, we call them FRCs, the family resource centers. That's what we call them. And so in the actual family resource center, the staff is a director, a clinician, family partners, family support workers, there's a school liaison, and our attorney is part of that team. And we work with them to achieve their mission of diverting kids from the court system to health and social services. And it says there what law created our family resource centers. If you're curious, it's chapter 240 of the Acts of 2012 by the Massachusetts legislature. And just to give you a little idea of all the things that are going on at our family resource centers, you know, they're working harder than ever during COVID-19. They've got these parenting support groups that are happening even on Zoom and online. They're doing tons of work around housing and public benefits. Sometimes there's little queues where you can apply for food stamps and stuff like that. There's referrals to mental health services. They've given out thousands of bags of food. I mean, it's very, very moving how in touch they are with their communities. And in that milieu, we're really proud to have our attorneys as part of the things that are, and there's more. So there's more things than the things that I've listed here, but I thought you'd get a picture. Our collaboration really has three parts. So I've already described that we do legal representation, and obviously there's a limit on our ability to serve like everyone that might need legal representation, but we have legal representation, and that's great. We do legal consultations really, and through weekly staff meetings that we have with the teams, as well as ad hoc meetings that we have with the staff as they bring cases up. Like this mom just walked in, she has X, Y, and Z going on. So a mom might have walked in to get a bag of groceries, started talking to some of the staff, and then now we're having like this ad hoc legal consultation. And then we're also doing these, we give out legal information. So we do trainings, we do statewide trainings on Zoom. We create different brochures and pamphlets and training materials. We train the staff, we train the community. So lots of information going that way. So it's really the three parts of the legal representation, the consults, and the information that we give out. So we're serving hundreds of families. And we do this by attending special education team meetings to advocate for eligibility for services and improved services, really seeing special education as one of the places where kids can get those therapeutic interventions right in school. We're seeking eligibility and services from state agencies. Here we have the Department of Mental Health, the Department of Developmental Services. There's also other state agencies like the Department of Public Health, et cetera. We advocate for diversion from the juvenile justice and child welfare systems. So sometimes that means going into a clerk magistrate's hearing or other probable cause hearing and arguing that charges should be dismissed due to lack of access to mental health services. And also we are very fortunate to have experts on our team that can give us information about health insurance and health insurance coverage. And so we ensure that families have appropriate access to health insurance and health insurance coverage. We prioritize some cases. We have a statewide intake line, which is really terrific. And we prioritize some kids who are boarding in the emergency department, kids who are being held in juvenile detention because of their unmet mental health needs. Sometimes there are state agencies, school systems, and other actors who are kind of playing hot potato with kids and everyone's in agreement about what kids need, but they might not agree about who has to pay for it. We have kids who are being excluded from school or suspended from school, and kids who are homeless. So those are kids that we might move along a little bit quicker in our process. I would like to show you a quick video. If that works, hold on a second. I'm going to try to, all right, hold on. There you go. So you can get a sense of what our collaboration looks like with our program. Let's make that bigger.
When Tristan was a baby, he was the perfect child. He didn't cry. He was playful. He was loving. He was always smiling. He slept through the night. When Tristan was 2 years old, he was in daycare, and they were calling me almost on a daily basis to come get him due to behavioral issues, to tantruming, assaulting other children. to where he got kicked out of daycare due to the demands of having to go get him all the time. I've lost 2 jobs. He did start public school in kindergarten, and he didn't fit at all. I would have to go get him. Things would get chaotic, and he would be under the table, banging his head or crying or trying to run out of the building because he was so overwhelmed and didn't know how to deal with these types of situations. And that's the part that was really rough, you know, seeing him struggle, wanting to fit in, but really couldn't, and it wasn't his fault. After kindergarten, I got him into a special program for kids with behavioral issues.
The mental health advocacy program for kids diverts kids from the juvenile justice system that are there solely due to their mental health needs. The kids that we work with are complicated. They're struggling in school, they're psychiatrically hospitalized, they're boarding in emergency departments, they're being held in detention, they're struggling in their communities. Sometimes they run away from home, sometimes they're being sexually exploited, and all of this because they're not getting the mental health services that they deserve. Investing in kids prevents costly interventions later. If we can access an educational setting for a child who's struggling in school, then they're more likely to graduate from high school. They're more likely to be gainfully employed.
The mission of the Family Resource Center at the Home for Little Wanderers is to do whatever it takes to help families. As social workers and human service professionals, we're often called upon to support families with issues relating to the law and to the courts. We're not trained in a way that attorneys are. And having an HLA staff attorney present in our office 40 hours a week, full time, has been a game changer for us. Families tell us all the time that the ability to work with an attorney made a life-changing impact.
Mental health services for kids can be something as extreme as a residential setting, but most commonly it's not that. Most commonly it's services in the home or in the community. It's great to be in the family resource centers because that's where the families who need us are. They're going to the family resource centers because they don't want their kids to be involved in the juvenile justice system, because they do want their kids to be successful. Obviously, low-income families can't hire attorneys on their own, and so this service, it changes the lives of kids.
Something bad happened. I had to go into the ambulance. I swear at the cops. Didn't go so well. But now I'm doing better, so then I can go home and those things wouldn't happen anymore. I'll have a better life.
For 5 years, my son was in and out of short-term stays because nobody wanted to pay for him to be in a residential setting. I didn't understand why nobody would step up when possibly later on they're going to be paying for his incarceration. And that's what scared me the most and what's made me fight for him as much as I have, because I don't want to see him behind bars. And that's the struggle of this disease. We know what they need, but we're not financially able to get them what they need. And I just think that it's just so unfair. Last year I got involved with health law advocates. And once I had an attorney coming with me to these meetings, things changed drastically. I was suddenly taken more seriously, and within a month he was approved for residential. Tristan's in, a much better place now because of the health law advocates, and so am I.
Okay, let me just come out of that space. That gets me every time when Tristan talks, it just gets me every time. So let's talk about where our kiddos come from. In this study, we have over 727 families, and 29% of our referrals come from the court system or the legal system. So that's court clinicians, probation officer, judges, and about 20% of our referrals come to the family resource centers. So they are directly referring to us. And then we have a mixture of other folks in the community that send referrals to us, including about 13% from healthcare and health centers. The participants in our program are about the average age of 12. We have kids as young as 3 years old, and we go up to age 22. In terms of baseline school engagement, a lot of our kiddos have been held back or repeating a grade. About 46% have been sent home, like Tristan's mom talks about in the video, Heidi. She talks about how he kept getting sent home. Sometimes we call those soft exclusions because they're not technically kids who are being suspended, but they're being sent repeatedly home. And as she described, it impacts their financial situation. We see that a lot with families where parents lose their jobs because they're repeatedly having to respond to school complaints. And 40% of kids had been suspended. A lot of our kiddos are court involved. Over 62% had open court cases. 75% of that group of kids are status offenders. So these are not delinquents. These are kids who are truants, running away, or what we call stubborn kids who are struggling to follow the rules at home or at school. About 98% of the kids that are referred to us have at least one diagnosis. The average is between 2 and 3 diagnoses, mental health diagnoses, and the maximum is 7, which to me indicates that they don't know what's going on with this child, because 7 diagnoses for a 12-year-old is a lot of diagnosis. We do collect data on our parents, and we do a baseline. So similar to what Eric was describing, the parental rates of depression in our program are higher than the published data. So about 62% of the parents reported symptoms of depression, and that's compared to only 19% in the published community data. 31% of our total sample had scores that indicated major depression, which if you compare that to the national prevalence is still very high. And so really what this correlates is that the high unmet mental health needs of the adults in the household, we associate that with how the kiddos and the youth are functioning or how the family is functioning. We give the parents at intake a strength and difficulties questionnaire that the parents report how they're doing. About 243 folks filled this out. If you look, what's clinically significant about this data is that only 14% of the parents reported their children in the normal range of total difficulties. So 77% were in the abnormal range. And in terms of parents that were reporting what those difficulties are, we have the description that these kids were having difficulties with emotions, concentration, behavior, or getting along with others. And as you can see, 47% of the kids were having severe difficulties and 40% were having definite difficulties. Only about 10% were having minor difficulties or no difficulties with their emotions, concentration, behavior, getting along with others. A lot of folks ask me, what are the barriers to mental health care? The 2 biggest categories are bureaucratic delay, which is being described by Boston University School of Public Health as difficulty navigating the paperwork and the eligibility processes. And incomplete information is that the folks that we work with don't know quite where to access services or how to access them. And so those are barriers that our work is specifically geared towards addressing. I can run really quickly. I know there's interest in COVID data. So we did a smaller sample around COVID data. We sent weekly questionnaires out to families and they completed them. Going along with what Eric had described earlier, 48% of the families lost income during COVID-19, 25% lost reliable childcare, 21% of our families experienced a family illness or death from COVID-19. And if you can see, the pandemic caused our families to have 21% experiencing a loss from family illness or death, but the pandemic also caused our families to lose income at a much higher rate of 48%. We had families who had a change in housing or had housing household changes in which family members moved in or out. In terms of our weekly logs, we had our families complete logs about who's in person, who's in hybrid, and who is attending school remotely. And so that data is in front of you. Really what we learned from the weekly logs is that families were reporting each week was a little bit worse than the next. About 30% of our families are saying that things were going worse at home and worse at school. And a lot of those challenges from week to week were behavioral health observations that the families had made. So about the median or mean of concerns was about 4 behavioral health concerns per week, with 10 concerns being the maximum. And when we asked families about what those concerns were, really those behaviors were around anxiety, verbal aggression, negative self-talk, physical complaints, stomach ache, headaches, depression, work refusal, really seeing more physical aggression and property destruction, and really our kids having a tough time navigating COVID-19. And I know earlier when I was talking offline with Bethany, she asked me a little bit about the emergency department crisis that we're seeing here in Massachusetts, and I know is an issue nationwide. We have about 140 kids boarding in the emergency department. Boston Children's reports to me that, we're seeing an increase in suicidality. We're seeing more kids with eating disorders, more kids with self-harm. So this is something that's really coming to a head during the pandemic as well. And COVID has impacted this in 2 ways. Obviously, as Eric had discussed, the pressures of the pandemic have been really intense psychologically, but also there had been some beds that had to come offline because of social distancing and ratios. The good news is that Boston University School of Public Health also tells us that we have a proven track record of significantly improving the lives of high-risk youth and their families. We're decreasing emergency department mental health services used by kids. We're decreasing psychiatric inpatient hospitalizations for kids. We're improving school attendance. Our truancy is really terrific. And we're significantly improving the overall mental health of kids, their caregivers. We're decreasing rates of family conflict, parental rates of stress and depression, and we continue to collect data around this. I know that we're running close to time, so I'm going to stop sharing in case folks have questions.
We do have some questions that have come in. And so before I know we have a couple of prepared questions, but let me get to the audience's questions first. Before I do that though, let me, number one, ask everyone to make sure they fill out the survey. We're going to plug a link in there now so that you have the link and can fill out the survey, and also thank Arisol and Marisol and Eric for presenting today. So the first question from the audience, Eric, I believe while you're presenting, a question was posed about the tools that were used to assess the impact of mental health. Are you able to share a little bit about the tools? I think that question was for you.
It depends on, there's just, there are so many tools that are used for different mental health problems. I'm happy to, if someone has a question about like depression, there's a very commonly used tool called the PHQ-9 that's publicly available. So I'd be happy, but that's just one example. But for every mental health problem, there's multiple measures. So there's different suicide screens, there's different alcohol and drug use screens. So I'm happy to share those with you but there's a lot.
Thanks. Mm-hmm. And so what we'll do is we'll do in our follow-up email with like the recording and the slides again and stuff, we'll share a few of those. So just folks, when we do the follow-up email, we'll try to get some questions answered as well in there. Next question, Marisol. There's a question about one of your slides displayed some of the, let me get it precisely on here, strengths and difficulties, the SDQ parent report. And so folks wondered if you had any of those questions, gathering that folks are really interested in some of the tools so that maybe they can also apply what you and Eric presented on today in their various settings. So can you share the strengths and difficulties questions?
I will reach out to Boston University School of Public Health because they're actually doing the data analysis. And if whatever we can share, I can send along to you. There is also our complete report, which I can share with folks, which goes in, it's 55 pages long, but we had a limited time. So I can share that with you, and it describes more in depth, like the questions that we asked the families. So for sure, I can share that. So.
Thank you. And then let me go ahead and continue with you, Marisol, and then I will lead into a question for Eric. Marisol, one of the biggest questions or most common questions that we get is how do you fund this, right? So when you describe the structure of your medical legal partnership work with the state at family resource centers, can you give folks some insights into like what resources finance-wise really support that work?
So I saw that my executive director signed on, Matt Seelig, so I'm going to give him a shout out because he has been really terrific, working really hard to make sure that our program is well supported. And you know, really at this point in time, you know, about 65% of our program is funded through public dollars. So we are fortunate, and I'm knocking on wood here because the budget process is still going on right now as we speak, but you know, we are fortunate to have an earmark in our legislature. I think that so that about 65% of our dollars are public dollars. And that is in a line item in our budget through the Department of Children and Families, Family Resource Centers, which I had described at the beginning of when I was talking. We have private foundation dollars that we receive to fill in the rest of that. And also we are in the midst right now of starting our partnership with Boston Children's Hospital's Accountable Care Organization, which is part of these disrupt dollars that are available. And so we have been able to fund the program in a way through that. We have also had other partnerships with our Mass Health Accountable Care organizations here in Massachusetts that allowed us to access funding through the Health Policy Commission in our state, as well as the Attorney General's office had a special grant program that allowed us. So these partnerships with the Mass Health organizations, which is like Medicaid throughout the United States, became more how should I say, attractive when we were able to show the return on investment and the cost savings that were really related to our ability to show that we were decreasing inpatient psychiatric hospitalization and emergency department usage. That really showed an improvement in health and a savings in dollars. I think the legislature liked that too.
I bet. And so, Eric, I just want to come back to you for sort of a closing remark, because right now I think the healthcare providers especially are seeing, and folks in the greater public health space are finally seeing some major investments and attention to those social determinants of health, those social needs. And what you presented on is a specific intervention that says, hey, there's financial strain, and we've clearly shown the link to suicidal ideation and risk. For the legal partners and healthcare partners that are on the line that haven't yet, and I've seen a couple actually incorporate within their entities financial advice, financial services, what might be some tips that they can take away about the implications of what you're seeing through your research?
Well, I think there's a few take-home messages from it. I think one is that when talking with medical professionals, yes, suicide is a medical problem, but it's also a social problem, right? And so I think that one of the take-homes is to say, actually, even considering that mental health certainly contributes to suicide risk, suicide being just, it's been increasing for the last 2 decades, even before the pandemic, and is definitely on mental health clinicians' radar. But to have financial and the different, helping with income and employment and homelessness, I think that is something to add on to considering for suicide prevention. I think the second take home is that it is really cumulative, and what you realize is that if there's just something that focuses on one dimension, so like income support, that might help, but if people misuse that money, if they haven't gotten if they use it for substances, let's say, they might still go into debt and risk becoming homeless. So it's really cumulative in how they all begin to combine with one another. And so I think that those are 2 take-home messages that when you're implementing your medical legal partnerships and talking with clinicians, those are take-home messages from the research.
Thank you, very much appreciated. Marisol and Eric, we really want to thank you for joining us today, sharing not just what, research you're picking up on, but we know there's a lot more to come out. I know both of you are working on research that leads to interventions, and then for Marisol at an MLP, really the implementation as well. Just so you all know, what Eric's dual role, and he highlighted some of this, is that he's doing is with the VA. And so our work continues at the National Center with the VA to really build out MLP services for that specific population as well, those families, those children who are part of veterans and military families. So look forward to more from Eric L. Bogan and Marisol Garcia. We can't thank you all enough as well in the audience for taking time out of your schedules to join us today. It is May Mental Health Awareness Month, so I wish you all well-being. Take care of your mental health. Your mental health matters. Do what you can to get those breaks and be healthy, everyone. Thanks for joining us today. You'll get the slides, the recordings, and any other follow-up questions in our follow-up email. Take care, everyone.
Thank you so much, everybody.